Hello, everyone, and welcome to Clot Club on February of 2025. My name is Michael Jaff. I'm an angiologist and the Chief Medical Officer for the Peripheral Interventions Division at Boston Scientific. What a thrill it is to join an incredible panel to talk about this unbelievable shifting world of pulmonary embolus therapy. Honestly, I think back with my colleagues here, who you'll meet in a moment, about how this field has completely transformed itself through patient need, physician innovation, new technologies, and here we are. The key, of course, is do we have the data to help drive these decisions? And so that's what we're going to talk about today. And I'm going to hand it over for an introduction to my good colleague and friend, Stavros Konstantinidis.
Hello, also from my side, I'm Stavros Konstantinidis. I'm a cardiologist at the University of Mainz in Germany, and I'm also one of the investigators in the steering committee of the HI-PEITHO study. I cannot but echo what Dr. Jaff just said, namely that we are really now living in an era of revolution in the treatment of PE. We have not had this for many years. We have fought for PE in cardiology, in other disciplines for many years, and there was little interest. And now here it is, as you said, Michael, there is huge interest. There's such a large number of studies. And the question is, where are we now with evidence, and what are we to expect in the next few months, actually, not years anymore, but months. So this is an exciting era, and we have the best possible experts today to bring us up to date with what we have and what we can expect.
So let's give each of our illustrious panelists a chance to introduce themselves before we get into the meat of the discussion. Dr. Sharp, great to see you. Thank you for joining. Maybe a brief introduction, given that you're now in a new role in a new place.
Indeed. Thanks, Michael. So I'm Andrew Sharp. I'm Professor of Cardiology at University College Dublin in Ireland, and at the Mater Misericordiae University Hospital in Dublin is where I do my clinical practice. I'm also involved with both Dr. Jaff, Dr. Konstantinidis, and also Dr. Kuker in the running of the HI-PEITHO trial. We work together on putting together the protocol and running the study, and you're going to hear a bit more about that, as well as some of the other studies in the space. So I'm looking forward to the discussion.
Perfect. Thank you, Andrew. And of course, my longtime friend and colleague all the way back in the Boston days, Professor Niels Kuker. Great to see you, Niels. Maybe a brief introduction, although nobody really needs an introduction to you. We all know you.
Thank you, Michael, also for letting me participate in this meeting. The others, Stavros and Andrew. Thanks for being on board. I think it's a great pleasure. It is really a long way, our journey of pulmonary embolism. I still remember the times when we convinced Stavros to come to Boston to present on thrombolysis from his first randomized trials of MEPIT, then doing the PEITHO study. And now we are really a big step. We moved a big step. We have such a big study program, not only with Boston, with other companies. I'm very happy that we can share this also tonight for the meeting.
I'll make my three colleagues smile and think that years ago, what we debated in pulmonary embolus was unfractionated heparin versus low molecular weight heparin. Like that was the hot topic. And here we are. So it's exciting. So I think with this, Stavros, I'm going to introduce Andrew to give us a review of the year of PE, a game-changing showdown. What a title. Andrew.
That's really a super title.
Thank you. You see my slides okay?
We do. It looks great.
Okay. Great. I'll kick off then. So the year of PE, is it a game-changing year? We very much hope so. We've got some clinical trial results coming out that could shape the course of this therapy for the next 20 years. So it's very exciting. These are my declarations of interest, which include being a consultant to Boston Scientific. So whenever I get involved in device therapy research, there's one question that guides my decision as to where to focus. And it's, is there a problem? Right? That might sound like a statement of the obvious, but there are actually many conditions where they're already pretty well managed. And we're looking at the 11th, 12th device in that space to manage a small number of patients who have residual need. In pulmonary embolism, though, we have a substantial residual problem over and above those treatments that are used medically, such as anticoagulation, thrombolysis. If you look here, this is a seminal paper from 2006. It actually changed the management of pulmonary embolism all over the world. It was by a chap called Professor Andrew Cohen from King's College in London. And he analyzed VTE-related deaths in just 6 countries in Europe in 1 year. And he found an enormous number of people who were dying of pulmonary embolism. And many of the occasions we were only finding out on post-mortem. You know, when I was at medical school, one of the phrases that used to be said was that the most common diagnosis to make on a postmortem is pulmonary embolism. And so this began all these VTE prevention programs around the world that have made such a difference. But unfortunately, we still have patients presenting to hospital with pulmonary embolism who subsequently die. And therefore, we have a problem that still needs new solutions to manage. So what is the state of the current field in terms of patients with high-risk PE? So that's pulmonary embolism causing sustained hypotension of 90 millimeters of mercury or below, or a 40-point drop from starting blood pressure. To be honest, I don't really use that secondary criterion much. I focus more on the ones with sustained hypotension because I think they're a greater risk group. And this was a really interesting study from Portugal. And what it showed is that the mortality from high-risk PE is extraordinarily high. It is around 64% in 2018, falling from 74% about 8 years earlier. But if you take out that first 74% watermark, really mortality hasn't changed much in high-risk PE in Portugal. It's a modern first world country with excellent medical care. And this is higher than is reported in many registries, but those registries are to some degree biased because registries from organizations like PERT are reporting results from PE-interested hospitals and PE experts. And they're reporting mortalities of around 30%. But here we have a national sample of around 60% mortality still. So clearly, despite the availability of systemic thrombolysis, patients are still dying. And if you look at the rates of use of thrombolysis in high-risk PE in Portugal, despite the very high mortalities, only a quarter of patients in 2018 were getting it. So the gray group is the young. So the doctors used to give thrombolytic to them in higher amounts, about 1 in 2 patients in 2014. But even in the young, who you might perceive to have lower bleeding risk, we start to see a fall away in enthusiasm for these therapies, which are associated with intracranial hemorrhage and major bleeding. So the field is asking us for new solutions in this space. What about intermediate risk PE? So as you know, from Stavros's 2019 guideline, it's really shaped our management of pulmonary embolism and still does to this day. He categorized risk categories as high-risk PE for those with shock, low-risk PE for those with no evidence of RV strain and no aggravating factors. And then in the middle is this intermediate risk group, which are categorized according to whether you have RV dysfunction and/or an abnormal troponin or B-natriuretic peptide. Mostly we focus on troponin now. So an intermediate high-risk patient is one with RV dysfunction and an abnormal troponin, but who is not in shock. If they're in shock, they go up to high-risk PE. So how are those patients doing? Now, if you arrive in hospital into a cardiovascular unit and you have almost any condition and your blood pressure is preserved and you don't have organ failure, so that's who these patients are. They don't have outright failure of perfusion of the kidneys, the brain, and all these other organs. You would expect mortalities from many other conditions, let's say a heart attack, at around 2%. Look at the mortality here in intermediate risk PE. It is way higher. So if you do a risk categorization using the pulmonary embolism severity index, if you look in the bottom right corner there, if you're risk class 4, you have a mortality of 4 to 11% at 30 days. If you're in PESI class 5, it's 10 to 25%. Now, some of those mortality rates may have come down a little with more contemporary management, but they're still significantly elevated and way above those, for example, of non-ST elevation myocardial infarction, or even STEMI, STEMI now, the mortality is around 3-4%. So we definitely have residual risk in this population, not just in the high-risk patients, the ones in shock, but in the intermediate high risk who have got RV dysfunction and evidence of biomarker abnormality. And just in case you think the PESI score is over-egging it, here we have the BOVA score. It's another contemporary score saying that if you have a preserved blood pressure but elevated troponin, RV dysfunction, and tachycardia, you have around a 42% risk of death or hemodynamic collapse at 30 days. That's an extraordinarily high residual risk on anticoagulation. And so we clearly need something more. The question is, what should that be? So Stavros conducted the PYTHO trial with many other esteemed colleagues and showed that routine use of systemic thrombolysis was not appropriate for that group because it caused a lot of bleeding. So the question is, can we use some variant of that strategy, i.e. reperfusion therapy, whilst reducing bleeding and maintaining or improving on the efficacy of systemic thrombolysis? There's also this increasingly recognized phenomenon, which is the post-PE syndrome, that is not just avoiding death. A lot of these patients have significant symptom burden in the year after their pulmonary embolism. It can be breathlessness, fatigue, chest pain, dizziness, syncope. And it's a complex mix of physiologic, psychosocial elements that surround pulmonary embolism. But whatever is causing it, and there's many different things that feed into the post-PE syndrome, there's clearly a residual problem here that we need new upfront therapies to try and prevent these very high rates of either physical or mental disability. So we need new options. So one such option is catheter-directed thrombolysis. So Niels is going to talk after me, but we should really point out that the only major randomized trial of catheter therapies versus anticoagulation was led by him in 2014, the ULTIMA trial. So it's 59 patients randomized to ECOS catheter-directed thrombolysis with anticoagulation or anticoagulation alone. And in 24 hours, he showed that there was a much more rapid resolution of RV strain on echocardiography with very little bleeding complications from this therapy. This then progressed through observational studies like Seattle 2, which were designed to further test the protocol of 24 milligrams over 12 hours. It might be actually a little bit too much thrombolytic because there was a little bit of bleeding in that study that we didn't see in ULTIMA, which used 20 milligrams over a longer period of time. And we really emphasized just how little thrombolytic you have to use in optimized PE, which was a dose-finding study of 101 patients, where 4 different thrombolytic therapy mechanisms were used: 8 milligrams over 2 hours, 8 milligrams over 4 hours, 12 milligrams over 6 hours, or 24 milligrams over 6 hours, all through the ECOS device. And what it showed is that you can offload the right ventricle using ECOS catheterlysis with tiny doses of lytic. So 8 milligrams over 4 hours, 12 milligrams over 6 hours seemed to be the sweet spot. And so you can see we're coming down from 100 milligrams of alteplase down to 12 milligrams when you convert from systemic administration down to ultrasound-assisted lytic administration. And I've recently done some work with some clot researchers from Leeds, emphasizing that ultrasound does seem to potentiate lytic. It makes it work faster and it makes it more potent. So I think it is adding something to the mix, and we're going to learn a lot more from HiPython, which you'll hear about shortly. Real PE, very large real-world data, again showing very good outcomes, as did knockout PE. So 1.6% major bleeding is a very low rate of major bleeding in the real world, particularly when there's a lot of elderly patients involved. But we need randomized data and we need outcomes data. So I won't steal too much of Neil's show because he's going to do a deep dive into how this differs from some of the recently published data from other research groups. But we're looking at 544 patients randomized to ECOS catheterlysis with 18 milligrams and anticoagulation alone. And the primary endpoint is a 7-day composite of PE-related death, cardiovascular collapse, or recurrent PE. And these are the enrichment criteria. So we're looking for some sick patients. So you have to have 2 of these categorizations. So it's intermediate high-risk PE, heart rate over 100, blood pressure below 110, respiratory compromise, which can be either respiratory rate up or SATs down. And although we've said systolic blood pressure less than 110, we are not taking patients in sustained shock. It's just if they transiently dip below 90 and stabilize at 100, we allow that. That's why we say less than 110. But we're not taking patients in outright sustained shock. Only those who have rebalanced onto a blood pressure typically between 90 and 110. If that is your criteria, you only need 2 of those 3. And the endpoint is a clinical one. So it's cardiac arrest, shock, ECMO, intubation, or sustained adverse vital factors despite more than 24 hours of treatment in the chosen allocation, which we'll perhaps go into more later on. So this really is a golden age of clinical trials. So is this year a game changer? We've got 4 major randomized trials plus HiPython, 5, that are going to give us some new information. So this trial is a little busy, but it basically summarizes HiPython, PLS2, STONE-PE, PE tract. These are all enrolling, and HiPython's almost there. We'll hopefully have the results towards the end of 2025. PLS2 is earlier on in its journey. It's 1,200 patients with slightly less severe PE, probably from when one looks at the enrollment factors compared to HiPython. That will probably be done by the end of 2026. STONE-PE is a design closer to that of Ultima, which is looking at RV-LV ratio in 100 patients, and that will be done probably towards the end of this year as well. And then PE tract, which is an NIH-sponsored study looking at any catheter intervention in intermediate risk PE, but it's got a very novel endpoint, which is cardiopulmonary exercise testing at 3 months, as well as some more functional things. So this suite of studies using either thrombectomy catheters, catheterlytic, or a combination is really going to give us a truly original insight. And this is a once-in-a-generation raft of trials that is going to tell us how to manage these patients with intermediate risk PE going forward. There's also one more called Persevere, which is a randomized clinical trial of 200 patients in high-risk PE, patients in shock, who will be randomized to catheter thrombectomy or medical therapy. So a really, truly exciting era. HiPython is going to be the first, though, to compare catheter interventions against anticoagulation in a large clinically oriented study. And it says more than 300, it's actually more than 400 now. So we're really on the final straight here. And if you are involved in any of these clinical trials, really try and put everybody in. We've got such a wonderful opportunity to collect data, to improve our understanding, and to improve care in these patients who hopefully I've convinced you retain considerable residual risk from their pulmonary embolism. So thanks very much.
Thank you, Andrew. That was great. We are going to have time for questions, not only from Stavros and me and the rest of the panel, but also from any of you listening. But we're going to go on to Professor Kuker, who's going to kind of give us a deep look at the differences between randomized clinical trials. I mean, after all, Niels, I thought one randomized trial is the same as every other one. So tell us, what's the difference between HiPython and Peerless?
Thank you, Michael. Can anybody see these slides?
Yes.
Yeah, we can all do.
All right. So yeah, I see we have a lot of people in today in the session, so maybe just some introduction. I don't have to say much, but everybody knows here probably that pulmonary embolism spans really a big spectrum of prognosis. It starts on the left-hand side with low risk or even incidentally diagnosed PE, where we actually still don't know what is the best for these patients, if we need blood thinners at all. Some people may consider the lung as a filter to filter out the small clots that may be not so important, but what I wanted to say that these patients don't die. They do well if we initiate anticoagulation therapy with the DOACs. On the other hand of the disease, we have the high-risk patients, and most here in this symposium probably have seen patients dying with PE and how dramatic it can be if you're not fast enough and if you're not placing these patients on ECMO and do a rapid reperfusion treatment. We all know the patients may die. And in the middle, still, we have these patients we are discussing today about is the intermediate risk patients, where we probably do much better than 10, 15 years ago, but current guidelines still say, well, treat these patients, the majority of them at least, with anticoagulation alone, because we don't have the randomized evidence to support the perfusion treatment for these patients. So this is where the HiPython study comes in. And as already Andrew mentioned very nicely, this is the first one actually that not only includes patients with biomarker or imaging evidence of risk, the troponin and the RV-LV ratio, but it also has clinical high-risk features, namely tachycardia, a high breathing rate, or a low blood pressure between 90 and 110, which we also think explains higher mortality. So the good thing is, I think we are really good. We also have a design that once the treatment was in 6 hours initiated, this is important because we shouldn't wait 2 or 3 days from selection of the patients to randomization. Then you may ask yourself, why do you wait from Friday to Monday? Probably the patient doesn't need any treatment if you wait that long. So 6 hours, and then the treatment should be initiated either with the echosonic system or with heparin only. So the primary endpoint is day 1, and I'm very happy when the Data Safety Monitoring Board, after 203 patients, says the study is in a promising zone. That means we can go on with the study. There were no safety concerns, so obviously the bleeding rates are not higher than previously shown, and we were able, by increasing the sample size, so we have an adaptive design and HiPITO that allows us to include more patients based on interim analyses. And I think we have more than 400 patients randomized, and we all hope that we're going to see the data by the end of this year at some point. Of course, there can always be a little bit earlier or later, but I think the year 25 is going to be a promising, exciting year, and we hope to see some really nice data then. So why is, I mean, when we designed HiPITO, and everybody can later discuss also Stavros, remember we had this discussion about the endpoint. I think it took us hours and days to decide, but I think we found a really nice compromise, because for the first time, I think we tried to omit any bias and any subjectivity in the endpoint. So of course, crossovers should be allowed to more other treatments if needed for the patients, but there's clear criteria when such an escalation of treatment was allowed in the study. So you see here that the endpoint is mortality, decompensation, or recurrence, and decompensation was clearly defined either by the presence of cardiac arrest or CPR, or by a clear shock with signs of end organ hypoperfusion. The need for ECMO is non-debatable, is clearly an objective endpoint, as well as intubation for respiratory reasons. And the national early warning score was shown already by Andrew, so I don't have to show it again, but a score of 9 is really high. That means the patient is tachycardic, hypoxic, and is not doing well. And this is obviously an objective measurement in the study that would also allow a treatment escalation. So just one slide about our own data in Zurich that we have published a little bit more than a year ago. Follow-up of the last 161 patients treated with ECOS. We also have more safety measures in our patients where we monitor coagulation parameters, including the fibrinogen. We are adjusting TPA dose based on coagulation parameters. And I think this is also a reason that our major bleeding rate was so low of only 1.2%, actually also confirming other studies like the knockout study, etc. Only also our death rate was a single patient that died out of these 161 patients. So the Peerless study, I was asked to speak about that. I mean, the Peerless study is a randomized trial. It compared 2 catheter-directed treatments, namely catheter-directed thrombolysis versus mechanical thrombectomy with a flow retriever system. The study also had inclusion criteria. At first glance, you would think these are clearly intermediate risk patients, but the more you look into detail, you would say, well, these inclusion criteria would also allow patients without any hemodynamic disturbation, let's say it, to get enrolled if they have a history of heart failure in the past or lung disease. That would have been enough to qualify for the study. So also studies were able to be randomized if there were no absolute contraindications to thrombolysis. Makes sense. All other patients basically that had an increased risk were not randomized and were treated with the FlowTriever. So interestingly for me, I know I also have to learn a little bit more. I have learned that if you read recent clinical trials, there has been this win ratio. So the PLS study is not the first one to use a win ratio. It's basically a hierarchical win ratio where you combine several endpoints that you think are important to see if there's subtle differences between treatment groups. You would use a win ratio in a trial if you think probably there's not a big of a difference. The mortality will be very low in this trial. And we are trying to see if there's subtle differences between the groups. So that's why there's a combination of mortality, bleeding, so intracranial, major bleeding. So these are objective endpoints, and then you have two more debatable endpoints that contain bailout, clinical deterioration, which is hard to define actually, and ICU admission, as you know, is like a protocol requirement and not much else. So the win ratio was really in favor of the FlowTriever system by basically an odds of 5. You would think at first glance, wow, the FlowTriever is 5 times better than catheter-directed thrombolysis. Well, if you look more detailed, you see that when you just look at the objective endpoints that are non-debatable, death, intracranial bleeding, major bleeding, there was actually no difference, not even a dot behind the comma. There was nothing difference in the main outcomes. However, the major bleeding rate that I saw in the CDT arm was 7%, and this is quite high. We can talk about this. There was actually in the recent studies on the last 10 years, there was not a single study showing a major bleeding rate of 7% with placing a central venous line into the lung and giving a few milligrams of TPA. So we can discuss this, but 7%, in my opinion, is unacceptably high major bleeding rate. And then, of course, when you look at the more debatable endpoints, like bailout, for example, in an open label study to even consider bailout is highly debatable. And they have shown there was a borderline significant increase in deterioration and bailouts we can discuss. I wouldn't even look at this because I think this is a very biased endpoint and this win ratio. And the worst actually and most dangerous thing is to have the ICU admission in the win ratio. So there was basically all the benefit was because of the transfer to the monitor unit. So let's talk about my criticism of the PLS study in a little bit more detail. The first thing I have, the PLS study probably would have made sense if we already knew catheter treatment is better than heparin, but we don't know that. That's why I'm saying PLS raises ethical concerns as of now, because it compared two investigational treatments with each other without having the routine treatment and the control group. And this is against all guidelines. And if I would have been in the ethics committee, I would have projected the protocol clearly, because it's too early to do right now such a study. And again, because there was no control group and not even a long-term follow-up, we don't know anything about mortality, bleeding, and CTEPH over the midterm or long term. And we cannot say anything about if the FlowTriever is any better than heparin alone regarding the main important outcomes. Go to the next slide. So this is not my last one about the criticism of PLS. It's only my second slide. I think the PLS study ignored the knowledge on PE risk stratification that we have learned from a lot of studies that clearly enrolled by that too many low risk patients. A positive troponin test was not even required by the protocol. It was just a component. Maybe if you had no history of heart failure, a little troponin bump, then you could go into peerless. So it was not required, and there was no clinical severity required, such as hypotension, hypoxia, or tachycardia. It was good to have it, but it was not required. A history of lung or heart disease was enough to get randomized. And this is all, these 3 points, in my opinion, explain that less than 1% of the people in the peerless study died. This is clearly not an intermediate risk population. It is rather a low risk population. The problem that I also mentioned earlier is, why would you accept a delay of 3 days in a randomized trial? I think this is another unethical aspect of the study. This is, to put it even as an inclusion criteria, that 3 days are good to initiate treatment. I mean, remember when we did the EMEA studies, I also participated. To wait 3 days to treat a STEMI, would you think this is a good protocol? I want to debate that very much. There were no standards. I think this is one of my main criticisms. If you have centers that are really interested and also, let's say, have experience with the FlowTriever, but have no experience anymore to use TPA, to place lysis catheters, to get the phone calls in the middle of the night to adjust the TPA dose, to look at lab values, then I would think that the 7% major bleeding would be explained by that. So there were no standards set at all in the comparator group. Any device was accepted. Any TPA dose was accepted. They didn't even care. The heparin dosing, as we all know, is very important during thrombolysis. There was not a single safety standard set for the comparator group. And the worst thing comes last. The peerless encouraged FD patients not to be transferred to the intermediate care unit, because if you have, if the procedure is good, the patient is better, why would you send such a patient to the monitor unit? The TPA patients, we all know, TPA is a drug that needs to be monitored. Also to neuromonitoring, it's not just the blood pressure and the ECG that you monitor, it's also, you need to monitor for bleeding complications. And this has to be done on a monitor unit. It doesn't need to be an ICU, but at least an intermediate care unit is required for CDT patients. So if you put this into a win ratio, it's just a protocol requirement, nothing else. It doesn't say anything else. So this is the problem. And again, the non-standardized CDT and peerless centers with little experience for CDT explains the high bleeding rate of 7%. It also explains that the bleeding rate is 3 times higher than published in the last 10 years. The standard protocols based on with monitoring of coagulation parameters published from our group, actually in our group was 1.2% major bleeding. So it's actually 5 times higher in peerless than in our data. So, and that's why I don't like the study so much. I have to say, if you compare apples with peers, it's really difficult to make a good conclusion out of the study. But again, there's one thing, why were 42% of the FlowTriever patients sent to the ICU? I mean, this was a low-risk population, nobody died. They could have been more courageous. That should have been 1% or 2%, not 42%. I mean, nevertheless, the last slide, the primary endpoint is a distortion of various findings because the win ratio included a mix of very hard endpoints with protocol requirements and highly subjective outcomes. The win ratio turned out to be positive in favor of FlowTriever 5 times better than CDT because only of a monitoring requirement for the CDT patients. This is the only advantage in this trial. And if the authors say the FlowTriever is superior to CDT, in my opinion, they have not done a good job. They shouldn't be congratulated for this study. I'm very sorry to say that. And why peerless will have little impact on consensus guidelines, we are all sure about this. The upcoming HiPITO study is the first one large enough to draw a conclusion about should we do anything else than heparin alone for these patients in the future? So thank you very much. The last slide is the flow chart that should have been added to the publication to make it more clear how the win ratio worked in the PLS study. Thank you very much.
Well, as only Professor Kuker could deliver, you were in fine form, Niels, so thank you for that. We are going to take the slides down and put us back on the screen and open it up to the audience. We've got a lot of people listening, so please chime in. I'm going to get to the first question in just a minute, but I want to ask Niels in follow-up to your presentation. Will I even get you to say that the sponsor of Peerless should be congratulated for actually successfully completing a large-scale prospective randomized trial in PE? Forget all the endpoints, forget all the ethical concerns you have. There have been questions that you and I have heard over the years that the reason we don't do PE trials is because they're too hard to enroll. Will you at least give that credit?
Yes, I would give one credit. I mean, my conclusion of Peerless, I should have been also a little bit more positive also for the authors and also for the company. I like the flow retriever. Our group was the first one to publish ECMO in combination with the flow retriever, and we still like it. We just saved a patient yesterday that had 90 minutes CPR, and he opened his eyes today after the flow retriever. So yes, we like the device, but we want the device to be used properly. And I think what we shouldn't do is to treat low-risk patients as of now. The one conclusion about Peerless for me that makes sense is that in a mostly low-risk population, the flow retriever doesn't kill. It has a very low mortality and is safe regarding mortality. That's what I would say about Peerless. But anything else, especially, I think what is not true is the safety. 7% versus 7% is not the truth. And that's why I cannot use much more than the mortality rate also of Peerless.
Great, thank you. Look, I think all four of us will say that there's not one answer for every PE patient that's sick, just like there's not one answer for any sick patient you take care of, no matter what illness they have. So we're not saying everybody should get ECOS. We're not saying everybody should get flow retriever, but you need data, right, Niels? You need data to drive your clinical decision making.
Yeah, exactly. I agree.
Stavros.
And there's more studies coming out, and I think we will learn much more.
For sure. Stavros, can you walk through your answer that you typed in for the audience that may not be sitting by the computer? So it was a good question from the audience. A patient arrives to the ED with mild shortness of breath. ECG shows sinus tach. Lab values show a mild positive D dimer. Should an angio-CT be considered?
Yes, Michael. So this is a question that is a little bit, it's one step before knowing what to deal with the patient. Actually, it's one step before knowing that the patient even has PE. So this is something that we have and others have dealt with over many years. Actually, that was the work done by Professor Arnaud Perrier almost 20 years ago, and also by Phil Wells in Canada, who tried to find out what would be the best way to develop an algorithm to arrive at the diagnosis of PE. That's not like STEMI, where you have, angina, you have the ST elevations, and you have the troponins 2 of 3. Patient goes to the cath lab. PE is more complicated because it's the symptoms are more non-specific. And so this is why we have this clinical probability. So clinical probability is not magic. It is a very simple score comprising patient symptoms. It comprises some vital signs like tachycardia. It comprises predisposing factors for PE, for example, cancer, or some sign, and also some clinical signs like DVT. And then there's always this subjective criterion at the treating physician's discretion, is an alternative diagnosis more likely? So you're asking yourself these questions, and of course I have to emphasize here, you're asking yourself these questions in a patient who is not in shock, because if the patient is unstable, you don't start calculating a Wells score or a Geneva score or whatever. Then you have Niels Kucher or Andrew Sharp, and they say, look, this is a patient coming in shock. I mean, is this a STEMI? You have an echo, you see there is a huge right ventricle. There is some information that speaks for PE. You can go to your cath lab, or you can decide to give emergency thrombolysis if the patient is collapsing or whatever. So this is now a patient who is stable, but then you do need a proper pre-test probability, and you have to document this probability. And I would advise anyone having been a witness sometimes or for testimony in courts. So it's always important to have the documentation. And then if you say the probability that I calculated, the pre-test or clinical probability is high, then you move on to the CT scan and to confirm or exclude PE. If your probability is intermediate or low, then you do the D-dimers. If they're negative, you don't have to do the CT scan. Otherwise, you do the CT scan. This is all in the sense, it serves the purpose of not doing too many CAT scans in patients, and so avoiding the radiation, avoiding the wasting of resources that may be unfavorable for other patients who may need the CT scan more urgently. And so that's the right way to go.
Let me ask Andrew, there's a nice question from the audience. What's it going to take for us to get a primary PE intervention, like a measure of quality of your program, right, Andrew? If you're running an acute MI program and you don't have a door to balloon time that meets quality endpoints, it shows that you're not really practicing state-of-the-art care and that you probably shouldn't be doing it. When will we get to that point with PE intervention?
Well, we have this interesting gap in the guidelines at the moment, whereby the ESC guidelines from 2019 state that if a patient with intermediate high-risk PE is deteriorating, they should become catheter intervention candidates. And there's a question of, well, how long do you give a patient? If a patient comes in with intermediate high-risk PE and their heart rate's 110, and then they shuffle around in their bed and it goes up to 130, and then, perhaps later on that evening, they get a bit behind with their fluids, or they get too much fluid given, and then they look a little bit worse. So at what point do you declare that someone is deteriorating, or declare someone is failing to get better? We've all managed these patients who sit on a monitor with a tachycardia banging away at 110 for 5, 6, 7 days. And at what point do you draw the line? So at the moment, the guideline recommendations are that to try anticoagulation, because a substantial proportion will improve, 85% in the top end of the intermediate high-risk range will get better on anticoagulation, but 15% will deteriorate. And then they need timely intervention. But because they've been medically managed for a period of time, they're actually harder to treat in the cath lab. For those who want to do thrombectomy, if you do thrombectomy on a patient who's had a pulmonary embolism 6, 7 days ago, it's a completely different procedure to those who've just developed a pulmonary embolism in the hospital ward down the corridor. Catheterlytic is probably a bit more predictable across the time spectrum, but it takes a little bit longer to work. So if you've got a super sick patient who comes in off the street with a blood pressure of 60, one of the safety aspects of ECOS is that we give a very low dose, and after about 3 to 4 hours, it's starting to offload the ventricle, and the process is complete in around 6 to 8 hours usually. With thrombectomy, in my experience, about 2/3 of the patients get better quickly, within an hour or two of the procedure at most. And so that is perhaps a more immediate treatment that responds to this concept of a primary pulmonary intervention. So that is being tested in the PERSEVERE trial. Patients in shock are going to be randomized to thrombolysis and/or anticoagulation if they can have it, versus a thrombectomy done immediately. The next level down of severity, so that's like your STEMI with shock. The next level down is sort of your STEMI unstable chest pain patient, and that's high python. We're taking the patients within 6 hours and initiating therapy within 6 hours. So I think that will drag forward this timeline that at the moment is a bit diffuse, a bit gray. When should we intervene? How long should we give anticoagulation? How do we define failure? How do we define deterioration? And I really think that's the beauty of HiPython, is it's going to give us some granularity as to how to define deterioration through the news score. So a news score of 9 or more predicts a 10% mortality rate, roughly. So if you're giving a therapy and they've still got residual 10% mortality risk, that tells you that that therapy is not working as designed. So I think we'll have now data to support that statement.
Great. I'm going to ask Niels and then Stavros to weigh in. I love this question. What about imaging for PE risk stratification? Niels, how do we use imaging today, and what do you think the future of that is? And then I'll go to Stavros.
This is a very good question. I think just short answer to a short question. We look at clot burden and we look at RV size. When we look more carefully, we can also see if the right ventricle is hypertrophic. If it's more than 7-8 millimeters, could be a chronic component. We should do much better in the future differentiating acute from chronic PE, because the acute PEs clearly will benefit more from perfusion treatment than the more chronic form. So this is something we need to look further into. I think one point also when we look at imaging is long-term care. And I think we need functional tests also for our PE patients, because we have learned that up to a third of PE patients have residual symptoms later. So we call it the post-PE syndrome. We just don't know what it is yet. I mean, we know if the echocardiogram is abnormal, but it is often is not. So functional testing like CPET, for example, to look for to inadequate rise of oxygen during exercise, stuff like that have to be done in the future. Perfect.
Thank you. Stavros, comments on that? And then another great question about how do you define clinical deterioration?
Yeah, so I agree with Niels, and I would also like to emphasize that imaging is already part of the risk stratification, so we do not need to add it. I mean, first of all, as Niels said, echo will tell you about the RV size. Echo can tell you if there are any free-floating thrombi in the heart, in the cardiac cavities, or through a patent foramen ovale, which makes this an emergency, and also will give you a clear hint on in which direction the treatment should go. And we have, of course, our CT parameters, or also our parameters with pulmonary angiography, which will help guide the catheter-directed procedure if this procedure is indicated, if the PERT decides that such a procedure must be performed. And as Niels also very well said, I mean, it's not only about direct risk stratification. Of course, in the acute situation, you want to save the patient if they are in danger, but it's also about parameters, CT parameters, and this is coming. I think the next guidelines will say more about this. There's already very good evidence to support it. There are parameters that will tell you first, yes, how severe is the PE right now, and second is what and how much is the chronic component, so what you will have to do in the future after the patient has survived the acute phase. And Michael, do you want me to say anything on failure of treatment, or is this?
Sure.
Yeah. So this is, of course, I would say it's one of the most difficult questions that we are asked, and that has not been really clearly answered by any guidelines or consensus statement. I mean, there's also no good data at the moment, because the data said, okay, so you'll have patient is deteriorating. Clearly, of course, if the patient is in shock, needs CPR, or if the patient needs ECMO, Niels said that, right? I mean, for the studies, of course, or if the patient is in a clear state where everyone agrees there is obstructive shock now, or whatever, or the hemodynamic collapse, then that's okay, that's clinical deterioration. The question is, how do we judge about clinical deterioration before we get to that, right? That's all what it is about. So how do we prevent that we arrive at this emergency situation? And this is also where studies and trials like HiPython will help us, because this is actually what is being tested in HiPython. Andrew mentioned it, and Niels mentioned it as well. We have such a system, and it was actually, I must say here publicly, it was Dr. Jaff who was the instigator of this effort, because until then we all had these parameters of shock has arrived, so what we're doing now. The question is, what do we do before shock comes? And then was the question that based on the patient's vital parameters, using a practical score, the new score, we could measure this score regularly after choosing intervention A or B or heparin alone or whatever, and then we can regularly monitor how the patient is doing, if the patient is stabilizing, doing better, or doing worse. And so when the HI-PEITHO is finished and when we have the results, these results will also indirectly validate the value of this score in determining and helping to define deterioration. There's more than vital signs to deterioration. Many experts, for example, the Cardiac Society in Germany does what I think many people do, and I'm sure that Niels and Andrew also do that. There are lactate levels that may help define that the patient is deteriorating, so it's not just about the heart rate, but nevertheless. So I think we are getting there, and I think that within 2 years, we'll be able to answer a question more concretely, a question that always is being vaguely answered, has been vaguely answered until now. This is one more collateral benefit of the ongoing large trials, and particularly HI-PEITHO, I would say.
Great, thank you. We've got about 4 minutes left, so I'm going to pepper the panel with some really great Clot Club questions. Niels, here's one for you. Hemodynamically stable patient, bilateral main pulmonary artery emboli, not saddle, but proximal main pulmonary artery. Should you go with CDT or anticoagulation or flow retriever? What do you think?
Yeah, so the imaging is one aspect, as said earlier. I have, of course, look at the CT scan. I mean, the CT scan, if you see very little clots and the RV is very small, it's really good to know, and then probably we do nothing except anticoagulation. But if you see let's say a large central PE with both main pulmonary arteries more or less obstructed, not maybe even without a saddle embolus, and you see the RV-LV ratio is large, honestly, in my center, you have to give me a good reason not to treat this patient. We may be a little bit aggressive, but the reason is also because we have a very good system in place that is safe. We feel very well. Also, our nurses are trained in the middle of the night. Everybody knows how to handle the ECOS control unit and so on. So it's probably very easy in our hands, and we treat maybe a little bit too many patients. But again, most patients with a large PE and a large RV, if there's no contraindication, we consider for treatment.
Perfect. Andrew, this is perfect for you. I love this question. So let's say HI-PEITHO is positive. Is this going to blow up cath labs? Like, how is that going to be managed? Should every cath lab be ready to treat a PE? Are the regular acute MI cath labs ready for that? Maybe it should only be PERT centers. How do you answer that?
Well, HI-PEITHO is like an evidence bridgehead into catheter therapies for PE. It's not looking at every type of presentation. It's taking the sickest out of the intermediate high-risk category and looking at those. So probably it's a few percent of the total PE burden. But it is like the anterior STEMI within 3 hours. That's how we started with primary PCI for STEMI. We took a group that should have the most to gain, and then we randomized them to intervention versus medical interventions. And so I think this will give centers an opportunity to start therapy and therapeutic programs in a manageable number of patients, maybe 30 a year in their center. And if they're just looking at a large, 1 million population, they can get their staff trained. They can start doing these interventions. They'll realize that ECOS is a super simple procedure. You can train non-interventionists to do it quite easily. And then as the data expands, so we're getting more patients in PLS2 with different criteria, we're getting more patients in PE tract. I suspect that will cap off at around potentially 150 patients per year per million population that you serve. That's probably the top end of where PE might end up if these trials are all positive. And so that's manageable. Like we do around 1,200, 1,400 PCIs for coronary disease per year in our center. And so an additional 150 cases is not going to wreck the place. There is a geography issue, though, because I think you'd have a little bit more time to transfer these patients. but you don't want to have centers doing 1 or 2 cases a year. So it might be that a network approach is followed, and I think that would be a good thing for patients if it was.
Well, the problem with Clot Club, Stavros, is we just get going and the hour goes away so quickly. I mean, everybody loves these. I love them. I learn a lot from listening to the discussions
Yes.
and the questions. Stavros, maybe take a few minutes to wrap up on your final closing thoughts here for Clot Club in February 2025.
Thank you, Michael, and many thanks to Niels Kucher and Andrew Sharp for their great and passionate presentations. And I think what we were able to talk about again today was, first of all, that risk stratification of PE is not just a toy, but we do want to find these patients who are at risk, in whom our decision will be important for their health and maybe their life in the hours or even minutes to come. And this intermediate high risk category is not just a name, is a category that has come out of major trials and is a category, the definition of which is evolving, of course, and this is exactly what the trials are contributing to. I mean, we are enriching the criteria for really defining those who need help. Otherwise, we have low-risk patients, as Neil said, in Peerless, who are being treated with catheter procedures. So this is evolving, but these are the patients we are targeting. And what is also coming out is that, indeed, we are very happy that finally, after many years of work, we now have major RCTs ongoing. But an RCT is not equal to another RCT. And I believe this has become clear. RCTs have to have rigid and standardized criteria. I must say, I do not like what some people call pragmatic RCTs. So there is pragmatic trials and there is RCTs. The RCTs have to have standards. We have to compare with the current standard of care. We have to have standardized arms in both the intervention and the control arm. We have to have clear outcomes, and we have to have medically relevant outcomes. Statistics is one thing, but the statistician will calculate for the outcomes that we will define as medical experts. The statisticians do not define the medical outcomes or endpoints of the study. And these are the criteria of quality that must be there, and then will come the real world studies. So this is what HiPytho is doing. This is why we are proud of this study, because it's a collective effort of many countries from 2 continents. And this is why we believe that this study will set the standard of how to manage, not just on whether to give echoes or not, but it will be on how to manage these patients at higher risk, for whom we are worrying what might happen. So I believe we have really made a lot of progress. Even before the end of HiPython, we can say we have learned a lot, and I believe we're going to learn much more in the months to come. And I'm really very happy because, like Niels, I've also been around in European guidelines for a long time, and I think the next guidelines, which I don't know who will write them and when, but at least they will be finally able to have some clear recommendations based on clear evidence. And that will be really, I think, a huge benefit for PE and for the patients concerned.
Well, let me thank you, Stavros, as always. Beautifully summarized. Andrew, Niels, great to see you. Hope we can have you back for another Clot Club in the future. Have a great day, everybody.
Thank you so much, Michael. Thanks, Stavros and Andrew. See you very soon.
Bye-bye to you all. Bye-bye. Thank you.
Cheers.